and it is my absolute pleasure to introduce our moderator, Dr. Amanda Fader. Thank you so much, Dr. Fader, for doing this. Dr. Fader is the president-elect of Society for Gynecologic Oncology, and she's also the professor of GYN and obstetrics and oncology, vice chair of surgery, and the director for rare gynecologic cancers, for the Center of Rare Gynecologic Cancers. I'm just going to give up everybody's titles here. At Johns Hopkins, did I get that one correct? Okay. Welcome. Thank you so much for being here live now for questions and answers. I also, so I'll open it up to you to ask some questions and open it up to everybody who's participating. And let's see what happens.
Thank you, Dr. Hope. And it's such an honor and pleasure to be back at your wonderful course. I really think that this is one of the best courses in the business for any cancer survivor groups. It's an amazing course, and thank you again to you and Dr. Hardesty for leading it. Hello, my friends. It's great to see you. Those were really fantastic talks, and you are true leaders in areas of cancer care disparities, post-pandemic cancer care, and how do we move forward. And we have a couple questions. I'm going to start by asking Dr. Cabale, why are endometrial cancer rates rising? Why do we think that's happening?
Well, thank you for the question, and thank you for inviting me. I hope you all can hear me okay. I'm in this busy hotel and like trying to be in a corner. So pardon me for that. But why do we think they're rising? I think they're two separate issues. We see a rise in endometrial cancer among young women, and I think that, well, people hypothesize that that's related to obesity and overweight and extra estrogen exposure for those type 1 endometrioid type cancers. And then we see another spike in increasing rates and incidence amongst Black women and other marginalized communities. And so the question is, there's some sort of environmental factor in addition that's occurring here. Because these are the more aggressive cancers that are not related to estrogen exposure. So there could be something related to socioeconomic status, environment, but also we have not fixed this issue of proper access to healthcare in a timely manner. And even if you do have access to healthcare, what Dr. Dahl and others have shown is that we've done a lot of studies in women, but not always included Black women in these studies. So that endometrial thickness, the lining of the uterus, those studies did not really include a lot of Black women. So we're making these assumptions that the same diagnostic test applies across the board. So there are multiple reasons, but those are some of the main ones that are being thought about.
Yeah, I think you raise a really excellent point that with these amazing clinical innovations and treatments that are being presented today, they're going to be undermined and outcomes are going to be undermined if either access to care is not there, or if the populations we are studying aren't diverse enough to answer the questions for each of those populations. So my next question for you was, for ethical, societal, and scientific reasons, we like to have diverse populations. How do we address the issue of minority representation in clinical trials? I know that's a very broad question.
Well, it's an important question. I'm at, that we were at the national clinical trials meeting that just happened in Orlando, and this is where Dr. Moore was and Dr. Richardson earlier. And this is a very important question we ask in our own cancer center. Multiple reasons. Again, one, the funding for clinical trials is really not great. It really isn't. And so how do we expand the funding to include more patients? So there's some structural problems that we have there. There's some issues in really making assumptions sometimes that Black patients don't want to participate in trials, which I think is a very big problem. My own mother passed away from a very aggressive recurrent leukemia, but she was able to live longer because she participated in clinical trials. But I was her daughter. So I was the person who really was able to advocate on her behalf, but she would otherwise not have really been presented with those options because they made assumptions that she was a 70-year-old Black woman who wouldn't be interested in clinical trials. So I think we have to be very, very careful in assumptions from the healthcare standpoint. And then I think that there are a lot of real reasons that patients don't want to participate in clinical trials, especially many people from Black communities across the United States. I think, as I talked to you, I just was texting my family, and we're just really traumatized by this yet another Black man who's killed, due to encounters with police. And there's just a lot of trauma and distrust with systems. And I think it's really important to, you don't have to be Black to understand that how terrifying it must be to think that you're entering a system that's not for you. And so we're not going to train the number of Black physicians and nurses that are going to be equivalent to the population. And that's why I'm so really thrilled to have the opportunity to talk to you all today, because I think empathy is what's required, and respect amongst all of our clinicians and physicians in our communities, so that we can properly take care of patients, even if they don't look like us. So a roundabout way to answer your question, but thank you. And I was looking at, I'm sorry, I know, I just want to say that I came in really late last night, and I feel like I was really not enthusiastic on my talk. But I want you all to know that I really, I'm very, very happy to be here.
Your talk was fantastic. We have the good fortune of having Dr. Alanis here in person. She's moderating a panel later. We're doing some work in Alaska, and then she's heading off to Winter SGO. So I wanted to invite her to the conversation. I know she had a question for you directly, Dr. Cavalli.
Yes. So I liked the quote where the patient, had stated, make sure that you find peace with your doctor. And I think you touched on this a little bit. So, what advice would you give a physician who's taking care of an African-American patient who may be, skeptical about what's being offered to her, something that could actually, delay care for the patient? How do they build trust with the patient, and how do they not take it personal that the patient doesn't trust them? And what advice would you give them to navigate that dynamic?
Well, I mean, that's a really great question. I mean, there are multiple ways to deal with this. I must add another thing about representation, because this has happened to me throughout my career. Sometimes because of just the systemic embedded kind of racism that exists, I've had Black patients not want me to be their doctor because they feel like they're getting the inferior they're being treated less than because they didn't get a white doctor. So I think that sometimes, all of this is very, very complex. But what I would tell people is you start where the person is. I've had a patient who has not wanted to be me to be their doctor, Black woman. And, but I was on call. And so I've just had to start from scratch and just to say, well, how would you like me to interact with you? I'm going to do my very best to take good care of you. What are your main concerns? And sort of walking real slow. If it's an emergency, you kind of have to be in a different mindset. But if this is something that you can walk a person through, is there somebody else you trust you would like to come with you to your next appointment so that we can talk about this together? I do a lot of drawing. I do a lot of showing people their actual scans. I ask first. I do a lot of education, lots and lots of education. And that's really hard in a healthcare system that wants you to see people in a brief period of time. And that's why courses like this are so important. I encourage, if that's happening, if that interaction is happening, I ask people to bring a friend or bring somebody they trust with them the next time. You don't push it. You get another appointment, or you actually offer, if you're not comfortable with me being your doctor, I can understand that. How could I help you get somebody you're more comfortable with? And I can continue to participate in your care, or I can refer you to somebody you're more comfortable with, and not take it personally.
I mean, I think to that end, you as a chair of OBGYN at one of our finest institutions, you've made this a mission in your career to really cultivate a diverse workforce pipeline that is going to be more inclusive, and so that patients see this is what cancer, this is what exceptional cancer care looks like. And I think by focusing both on the education interactions with patients and understanding culture and context and history, as well as working on this from the professional standpoint at institutions, I hope that, thank you for all you're doing in this regard. You're such a fine example of this for all of us. So we see a lot of disparities as well in the COVID pandemic outcomes, as Dr. Glaser beautifully presented. Are you seeing that most of your patients are getting their boosters? And what do you tell patients who are on chronic chemotherapy or radiation and are a bit immune suppressed? Like, when is the right timing to get boosted?
Yeah, great question. Thank you. In terms of personally, my patients, I think most of them have been vaccinated. I think, it's a little hard. I presented the numbers about the percentage in our country who have at least received one dose and then one full series or 2 doses for most. But only 30% have gotten a booster. Only 30% of people who have been vaccinated have gotten a booster. And so I think that's where we're working right now, especially with our cancer patients. And just to try to raise awareness about how much even covering the Omicron variant with the new booster that came out this fall can really be helpful, especially for our patients with cancer, especially if they're undergoing chemotherapy or radiation or about to have surgery. In terms of timing, really the only time that we need to delay a dose of COVID-19 vaccine is for someone who's having CAR T therapy or stem cell transplant. That's really it. Those are really uncommon treatments, especially stem cell transplant. CAR T is maybe a little in clinical trials now for GYN cancer here and there, but most of the time it doesn't matter at all when you get it. So when you get the vaccine. So just the encouragement for everybody is to just get the vaccine, especially if you're on active cancer therapy.
That's wonderful. And we get a lot of questions at our institution, so I'd be interested to know from both of you, when do you recommend an antiviral therapy for these patients, like some of the approved therapies like remdesivir?
Yeah, great question. So we have sort of an algorithm that we use at Mayo Clinic. We have some amazing COVID-19 nurses and nurse practitioners who run like this whole system of, you call in, you're positive for COVID-19, and they kind of run through a list of symptoms you're having, and then also comorbid conditions or other conditions you also have at the same time. And so those two things get combined. Most of the time for our cancer patients, it's considered a comorbid condition, especially if they have active cancer or are undergoing chemotherapy, whether or not they are actively immune suppressed at the moment. So those patients would qualify for the remdesivir or, one of the other treatments if the remdesivir is not appropriate. So yeah, I would say most of our patients would receive it because of that algorithm.
Wonderful.
Yeah, it's the same at WashU.
Okay, great. Same here. That's great. Great to hear consistency. Doctors Hope and Alanis and Hardesty, are you doing similar things at your institutions?
Yes, we are.
Okay, great.
Sure.
Well, it's good to hear that there's not always consensus in GYN oncology about things.
It's true.
I know that we have to wrap up. I'm just going to ask a couple more questions, and please, I invite our survivors and participants to submit questions to the chat. But Dr. Hardesty, I don't know if you just want to ask this question. You proposed a really very good question in the webinar chat.
So, Dr. Kabali, I always ask myself as a as a white doctor, basically, what are ways that I individually could do better? I like to think of myself as, not having bias and doing all of the things that you say, but, I think no matter what you think, there's always some subconscious things that you're doing. And, what do you think if you had to say to your non-minority peers, where do you see us making mistakes most? What things do you see from your perspective that, like day-to-day things that, might help us do better?
Well, I mean, I think that there are lots of parallels, right? There are lots of parallels between what people who are marginalized for whatever reason feel with other people. So I'm going to just give an example of being a woman in medicine or being a surgeon. So sometimes there are differences in the way we're treated. Sometimes people don't think you look like a surgeon. You're a woman. Are you really a surgeon? Are you really an expert? So remembering how that feels, so you don't have to have gone through that to know how just really bad that feels. And so if you see somebody else experiencing that, you can learn about it and ask about it. All of us have biases, right? It's just being aware of them and how we're sort of applying them, and then being clear about understanding and learning different people's histories. I think we just have so much more to do in this country around specifically anti-Black racism, but there's anti-First Nations racism. I mean, and you all experience that in Alaska. Anti-immigration racism, especially against Mexicans and people, Latinos and Latinas. And so you don't have to actually be, and I think people in medicine can lead in this front. And the example that I give is you don't have to have ovarian cancer to know that the person who's been diagnosed with ovarian cancer has to deal with a lot of challenges. So as the physician taking care of a patient with ovarian cancer, you don't have to experience all that person's experience to have empathy. The empathy centers around the emotion of feeling, uncertain, confused, in pain, wanting somebody to not abandon them, wanting to understand that next treatment. So I think that those principles apply in all these different places. And I think we have the tools to do it because we're cancer doctors. That's what we do every day. So I don't think it's a huge leap. You don't take it personally if somebody's really upset about their cancer diagnosis, right? So if somebody's really upset about a microaggression at work or you shouldn't take it personally. You can empathize. You can say, oh my gosh, and tell me about it. And how did that make you feel? And how can we help you feel better about it? And what can we do to change our environment so that this doesn't keep happening?
It's wonderful advice. Thank you very much.
Yeah, I'm really glad you brought up the anti-First Nation sentiment because I think that for us in our geographic location, that's really huge. One of the things I think that's really helped me is to really try to understand the perspective that those patients are coming from. And, in this particular situation, the bigger issue is just the completely endemic abuses that have happened to those patients. Help me. I try to really put that center in my mind when I'm frustrated because people aren't coming in for appointments or doing things that I tell them to do, or they're late, or this, that, and the other. When the life experiences that have led those patients to the point where they are often result in them developing terrible substance abuse problems. But a lot of time that's because their uncle raped them between the ages of 5 and 12. And, I mean, I'm just making that up, but it's like on a whole nother level, like 100-fold anything I've ever seen before. And so I know when that I'm interacting with people, from that sort of a background, I do try to keep that in mind when I'm, being frustrated about behavior that, from my perception is like irresponsible or whatever, but really it's a result of a lifetime of all the horribleness.
Well, I think that our time is up and we'll turn it back over on that note. And we will thank you so much to the wonderful experts today.
Thank you so much. Yes, thank you, doctors, so much. We really appreciate.
Thank you for having us.
Yes, thank you so much for having us.